Everybody, welcome. My name is Josie Ramirez-Herndon, and I'm the coordinator and host for today's event, Addiction Therapeutic Services. And again, I would like to welcome everybody. And I'm just going to go ahead and mention that I've been under the weather for the last week. This is my first couple hours out in 5 days, so I might be leaving a little bit early, but I wanted to be here to support a dear friend who's speaking for us, came all the way from LA, Dr. Jiim Golden, and to see all of you today for a few minutes. So thank you all for coming, and it's just a pleasure for me to host this luncheon every month. My husband Jiim is going to be emceeing. Yay! So have fun with Jiim. And then Yvette is going to MC with him, so we're going to have Yvette and Jiim. Yvette's our co-sponsor from Sovereign Health. So I'm going to be handing over the microphone to Jiim in a little bit, yes. And then I have a special Denise Klein. Where is she? Right here. She's also going to be emceeing. So we've got, she's from, so Denise, or Savannah. Okay. Somebody from Milestones, who's sponsoring the lunch, and Yvette and Jiim are going to take over and kind of do the raffles and all that good stuff. If you have any questions, you can go to either one of them, but I'd like to take this opportunity to thank our sponsors, which would be Denise Klein from Milestones, and give her a couple minutes to talk about Milestones.
Sure, happy to. How do you do this? Just
hold on to it.
Oh, okay. Just hold on to it.
Nice.
Happy New Year, everyone. We're so excited to be here, and Dr. Golden just joined our team at Milestones, so we've been so honored and blessed to have him on the team. He's doing such a great job with our patients. For those of you who don't know about Milestones, we're a 12-bed dual diagnosis treatment program. We're a very serious dual diagnosis treatment program. Take laptops, cell phones. People have to be very motivated to come in. And then we truly get to the underlying issues with our fabulous doctors, clinicians, and Savannah, my daughter, is one of our admission workers. So if you need any more information on the program, you can track one of us down, and we're just happy to be here. So thank you, Josie and Jiim, for this fabulous invitation. We're honored to be here.
And Yvette, would you like to talk about Sovereign Health, our other co-sponsor?
Hi, my name is Yvette, and I am an outreach consultant for Sovereign Health Treatment Center. Sovereign Health is a JCO accredited treatment center that treats mental health. We treat dual diagnosis, and we treat addiction. We have several different treatment centers in Arizona, San Clemente, Culver City, here in Palm Springs. We do treat adolescents from the ages of 12 to 17. If you have any questions about Sovereign Health, because I don't want to take up too much time, please stop and see me, and enjoy yourself. I'd like to say thank you to Josie for this wonderful lunch she puts on every month.
And of course, Seth, who pays for our lunch from Millennium Lab. Yay,
Yes, cheer for me, yes. Happy New Year. Thank you guys very much for having us. I'm with Millennium Health, so many of you have probably heard this little pitch many times, but for those of you that haven't, we are a laboratory with a specialty focus on drug testing and medication monitoring for treatment programs and treatment facilities. So what that means is we're doing all of our testing with a 24 to 48 hour turnaround time to help you do your jobs better and more efficiently. And we're also testing for all the things that you care about. So beyond the opiates and the amphetamines, the methamphetamine, we're looking at synthetic THC and kratom and spice and bath salts and you name it, we've got. So we exist to make your life easier and smoother. The less you have to think about testing and the more you can table that as an issue, the happier we are. So if you have any questions, if there's anything I can do for anyone here, please don't hesitate to grab me and pester me about metabolites and metabolism. Thanks very much.
Yay. He knows about metabolism. He's a bodybuilder. You have any questions about exercise? He's good. And then I'm going to have Nanette Zumwalt come up, and she's my partner with our Admissions and Marketing Symposium, so I'd like for her to talk a little bit about what we're doing in 2015.
Hi, good afternoon. I don't know how to follow Seth with that great radio voice he has. But so Josie and I started an admissions and marketing symposium. It actually is an actual training for admission staff and marketing staff. There's nothing like it in the country. We've done it twice. Last September and the September before in Los Angeles, and February 25th and 26th we're taking it to Delray Beach, Florida. Which, you know, when I was in Minnesota last week, that was a great trip, Delray Beach, Florida. I'm in Palm Springs, maybe it's not so great, but it's a beautiful environment. We've got some great speakers. There's a flyer out by the front if you haven't seen it. Great training opportunity. I don't know if you've been in the industry a year or 20 years. I think you'll find something new. SEO marketing, branding, closing calls, working with families, self-care. Self-care is a big one for admissions and marketing. I think people don't realize how much being on the road and being on those phones wear us down, even though if we're not in direct client contact every day. So check out the training. If you can't get to Delray Beach, Florida, February 25th and 26th, put September 2nd and 3rd in Los Angeles on your calendar. So that will be our third annual Los Angeles training. And again, great speakers. Visit the website anmsymposium.com. and come join us for a training.
And Nan, tell a little bit about Hired Power, because we go around the room. That's her company, is her day job is Hired Power.
So Hired Power, yes, my day job, and it is Hired Power. I kind of joke that people want to say Higher Power, and I say only my husband gets to call me God. The rest of you have to call me Nanette. So we're a transition company. We're all about getting people from home, hospitals, jails. We do interventions, safe passage, so we pick people up, get them to the door, treatment. We have about 90 personal recovery assistants across the country that go home with people in a transition phase, anywhere from the first 24 hours to 90 plus days, and get in there with a teachable moment. So it's all about mentoring in the home, practicing life skills and daily living skills. And then we have long-term case management and monitoring. So any type of transition. I have our program director here, Ren Goolsby, for our young adult men's transition program that just opened last year, men 18 to 26, and it is extended care that from primary to us they can stay anywhere from 90 days to a year, and we accept all insurances. We're in network with most and work out of network as well.
Okay,
Thank you.
And thank you for coming. She just drove in from Huntington Beach. Yay. Okay, and Jim, did you want to talk about ATS?
Oh.
Remember, I'm not talking that much.
Oh, she's not talking that much. Jiim Herndon, I want to thank everybody for coming. Happy New Year, everybody. I'm blessed. We're blessed to be able to do this work. You know, Josie and I have been working in the field for like, I don't know, a long time. I've been practicing addiction medicine for the last 13 years.
Can't hear Jim.
Okie dokie.
Louder.
We opened up ATS 18 months ago because we have the passion to help people get better. I've got a wonderful staff, wonderful therapists. You know, we need our clients where they're at so they can break the cycle of going into residential treatment centers, going out and getting stuck. You know, we wait for them to get stuck, and then we ask for a little more from them so they can break that pattern. I got honored to do an intervention, you know, basically an internal intervention on one of our clients yesterday. Our program director, myself, one of our really a wonderful man who runs a sober living, and basically we got to intervene on a man who was stuck yesterday, and that's what we get to do. It's fun. It's rewarding. And it's, you know, it's Josie's and mine. It's easy. Well, no, it's not. Anyway. Anyway, if you guys have any questions, we're doing tours after. I want you guys to come see our place. We just opened up another 800 square foot group room upstairs. We're really psyched for 2015, and that's it.
So again, we're just right on the other side of the parking lot from the Wells Fargo, so we're just, walking distance from here. If anybody wants a tour, just drive over to the next lot over. Jim's going to be doing tours with Marcia. And, like Jim said, we've got group rooms and therapist offices and stuff like that. But when you walk through, I think it kind of gives you a feel of the energy of what we're doing every day at ATS and where our hearts are with our clients. And we, like Jim said, we meet them where they are. We take insurance. We work with them financially. And we have our CARF survey February 1 through 3. So hopefully for our next luncheon, we'll be CARF accredited. So I'm very excited about that. Yes. Okay. So now I'm going to invite Marguerite Kaiser up, and she is actually Jim's stepmom. So she's family, and she has a foundation called the St. Gabriel Foundation, and I wanted her to share a little bit about that.
Thanks, Josie. Josie and her husband Jim are on our board of directors of the St. Gabriel Foundation. We are a nonprofit, and we give no-cost music lessons to children at risk. So we're trying to keep them from going down the wrong path and get them before you get them. We just did a pilot project in Killybrook School in Costa Mesa, California. Killybrook is a low-income elementary school. 85% of the student body is Hispanic. They do not speak English at home when they go home from school. They would never, ever in their circumstances have the ability to have private music lessons. So we did 60 children after school for 4 months. They were fabulous. They worked hard. They appreciated that we gave them lessons. And they played drums, they played piano, they sang. You may see them on our Facebook pages. And so now we're looking for money to do a full school program. The principal asked us to come in and do the whole school. When the district cut the music programs into schools, the wealthy schools had PTAs that went in and got instruments and teachers for after school. But the Hispanic schools have PTAs that can barely pay for the soccer program. So there are no instruments, no music teachers, no air conditioning in the music room, nothing. So we are looking for help, and we did this in Costa Rica, Central America, about 12 years ago. And now there are 7 schools in Costa Rica, free schools where everybody can have music and art. And there are 7,000 children receiving free music lessons. But we were able to get the city budget to give us 2%. So we built a school, built an auditorium. I'm not going to be so lucky as to get a municipality to help me, so we're looking for a little bit of help. And we need instruments, used instruments, and we need volunteers. And our first big event will be in April in Orange County, a dinner dance auction. And we need hosts and hostesses and money.
Did we mention money? Do you want to give the Facebook so that everybody knows?
Oh, yeah, it's St. Gabriel Foundation. Yeah, just Facebook / St. St. Gabriel Foundation.
Now, Marguerite, can you tell a little bit about your musical history and background?
All right, I am a pianist, and I started at age 5. Back in the old days, when I was little, everybody in the block took music lessons from the lady down the street. And my mother and grandmother and sister and everybody played piano. So then I went to sister school, and the teacher told my mother that she would have to sign a little paper every night that I practiced 30 minutes. And my mother's eyes got very large and worried about that. So she took me home that night and sat me at the piano and put a little clock up there. She said, now when the big hand is on 12, you start practicing. When it gets on 6, you can get up. And you can't get up before then. And so I sat down at the piano and I looked at that book and I fidgeted for a while and the hand never moved. But finally I opened up the book and I started playing. And then it was fine. And then everything's fine. It's just, if a parent doesn't make them sit down that first time, no kid is going to sit down and practice on his own. Somebody has to lead the way. Then they have so much fun. The 6th grade boys at Killybrook were sarcastic. There were kids that had different kinds of disabilities, speaking problems, impediments, and the teachers rolled their eyes at me and they said, oh, you're going to have fun. at the program, the teachers came up afterwards and they said to me, how did you get those children to talk? How did you get them to keep their eyes on you? And I said they were having fun. All of my children performed, and beautifully. And the third graders would help the first graders. And you know, it became a family thing, and music class was just fun. So, you know, I'm hoping that this will help. So then I went on to college. Now, Johns Hopkins did a 10-year study on music and its effect on children. And they had the group, 100 children divided 30, 30, 30. The first test group, no music. The second group, a melodic instrument, flute or something. The third group, piano. They tested every year. Each year, the music kids did a little better, a little better. By the end of 6 years, the piano students did 60% better across the board. Now, when I was a little girl, I thought I was getting better at piano because I was getting better in school. Now I'm wondering if maybe I got better in school because I was doing piano. I can't prove that, but in first grade I was ordinary like everybody else and making mistakes, but by the time I was in 5th or 6th grade I was at the head of the class and I was on my way to competition and I got scholarships and I got money and I got to play in 10 different countries in the world and 20 different states, and I'm happy, and I'm married to a fabulous trumpeter who is also a performer, and it's a fun life. And so, you know, I think we're on the road to diminishing the number of people you have to help and increasing the people that are happy with their lives. Thank you.
She's my hero. She's wonderful. Okay, I'm gonna have Yvette help me take the mic around the room, and so everybody can do a very quick, just your name and what facility or your practice, and then we're just gonna keep going along so that our speaker and each other will know who's here to network with after lunch and so forth.
Hi again, my name is Yvette Stone Patterson. I am an outreach representative for Blue Tiger. Blue Tiger is a sexual addiction therapeutic outpatient, what we call it, Terry? Outpatient program here that's located in Coachella Valley, dealing with clients that are traumatized, who need extra counseling, who may need some addiction help. I'm going to let Terry tell a little more about what Blue Tiger does, and then we'll pass the mic around a little more.
Hi, I'm Terry Gatewood, owner of Blue Tiger Recovery. And as Yvette said, we deal with those affected by addiction and trauma. I'm a somatic experiencing practitioner as well as a CSAT, which is a certified sex addiction therapist. So primarily most of the addiction has to do with that we deal with. If it's connected or fused with sex, then we like to see them. And also dealing with those with trauma, as even the NIH and CDC are all kind of on board now that most of the trauma or most of addiction is related to trying to regulate affect from traumas. So we try to combine the treatment for those. We're just down the road on Talkowitz, 2 blocks this way from the airport, so feel free to stop by and see us. Oh, one quick thing, we have our boot camp coming up on the 19th. We only have 2 spots left, so if you know somebody that would benefit from the intensive, it's from 9 to 5 every day for 2 weeks. And we are out of network with insurance, but we do accept Medicare. All right, thanks.
I'm Erin Fabricatore. I work as a physician assistant, and I'm not yet working here in this area, but looking to go into addiction medicine.
Hi, I'm Suzanne Stradley, and I'm with Sober Medical Solutions. We do naltrexone implants to support people's recovery.
Randy Stradley, her other half, Sober Medical Solutions. Again, we work here at the La Quinta Surgery Center and also in Placentia Surgery Center. Dr. Lai is doing the implants, so we're working with both the centers.
Dwayne Patterson, co-founder of Hearthstone Structured Living in Palm Desert, California.
Richie Annenberg with recoveryview.com, which is an online journal, and also membership chairman for MOT, which is a Men's Association for Addiction Treatment.
Roz Annenberg, and I am marketing director for Los Angeles for ATS. And I also want to announce to the ladies in the audience that we have a Coachella Watt meeting here once a month on Thursdays, and you can talk to Yvette after the meeting. It's a really important networking thing.
Leah, medical coder at JFK.
Darlene David, Awareness Program, DUI.
Izzy Harrison from Addiction Recovery Rehab in Villa Park, Orange County. We're a brand new facility.
I'm Dr. Simone Ravitas, and I do a lot of different things, but I work with trauma and addictions using neuroscience.
My name is Hedley Green. I'm the International Business Development Director for a company called Avera. We're a full-service marketing agency exclusive to treatment centers across the world.
I'm Georgiana Lotfi. I'm a licensed marriage family therapist. I also have a doctorate. I just moved to Palm Springs, and I'm a public speaker. I speak on meditation and recovery, 11-step work. I have 5 apps that are out. My easiest and app is a simple breathing app for 11-step work. It's called Room to Breathe. My most recent released app is one on helping people fall asleep.
I'm Sharon Rain. I am outreach and referral for Addiction Therapeutic Services, and I'm also going to be giving tours after. Thanks.
Hello, my name is Ashley Swain, and I'm with Oasis Rehabilitation Center, specifically Oasis Community Services.
And I am Curtis Carrasco. I'm also with Oasis Rehabilitation and Oasis Community Services here in the desert.
My name is Richard Lipfield. I'm a family therapist. I have offices in Mill Valley, California, and Palm Desert. I do experiential therapy, inner child work, psychodrama. I fly into rehabs and do psychodramatic groups and inner child work with clients. And I love my work. Thank you.
Hi, I'm Kelly Wright. I am a spiritual blogger, author, and I have a spiritual radio show. I am a new transplant here to Palm Springs. I'm interning with Michelle Garcia at Cielo Spiritual Retreat and Sober Women Living Home. It's a mouthful there. I did breathe, and I'm just glad to be here.
Hello, I'm Michelle Garcia, and I opened a women's sober home out here in the desert, and I am the founder of Active Recovery Solutions and Marketing Company, and I'm honored to be a part of ATS Addiction Therapeutic Services IOP as spiritual care counselor, bringing spiritual groups, and I love what I get to do today. And thank you, Josie, for holding this, and Jim.
Hi, Dr. Ray Montella, therapist, tool diagnosis, families, couples, addiction.
Tim Glenn, International Addictions and Anti-Aging Therapies, LLC, medical IV detox, and I'm fond of breath work, and also the sleep work as well.
Robert Teitelbaum, co-chair with Carol Teitelbaum for Creative Change Conferences, and we're also co-chair with Palm Springs Theater Sports, doing the Beautiful Face of Recovery, and also the men's group.
Hi, I'm Nicholas Warden from Boulevard Treatment Centers in Hollywood. I do outreach. We're an IOP, both day and now evening.
Susan Rigney. I'm a licensed psychotherapist in private practice in Palm Desert. I work with problem gambling. I also work with foster parents. I do a lot of training for foster parents and fosters training with Riverside City College. Thank you.
Hi, Jeff Brosnan, addiction therapist, licensed marriage and family therapist, president of the Desert Chapter of the California Association of Marriage and Family Therapists. Thank you, Josie and Jim, very much.
William Ali, LCSW. I'm a therapist, and I work as a clinical director at ATS. Thank you, Jim, for introducing me.
Sharon Zaris. I'm a licensed marriage and family therapist. I have a practice in Rancho Mirage and Indio.
Hi, I'm Katrina Ball. I'm an addiction medicine physician and also board certified in family medicine. I just provide withdrawal, detox management of chronic care diseases for anyone that needs it in the Coachella Valley.
I'm Tommy Vaughn. I represent His House. It's a men's addiction treatment center, and I represent New Creations Addiction Treatment Centers. We're located in Upland, Ontario, Rancho, Redlands, and Colton. We provide services from detox all the way to the outpatient portion of the treatment issues.
My name is Larry Aragon. I work for Benchmark Transitions in Redlands, California. Admissions and intake coordinator. Thank you.
Hi, Penelope Richards from Above It All Treatment Center in Lake Arrowhead. I'm a fitness instructor, yoga and dance, with a background, several Broadway shows to my credit. 28 years sober and a cancer survivor, so I bring a lot of personal experience to the, we like endorphins. That's a good drug.
My name is Andrew Golden. I'm here to hear my father speak. I'm excited. James Golden. You do a good job.
Hi, my name is Ren Goolsby. I'm the program director for the Young Adult Men's Breakaway program.
I want to say thank you to you all for coming and enjoying our company here at ATS and networking with us.
Hi, everybody. My name is Marsha Morris, and I do marketing and business development at ATS with Jim and Josie and all of our wonderful staff. Glad you're all here. I want to let you know about our next luncheon before you even finish lunch at this one.
Put it in your book.
Yeah, right. February 6th, they're always on a Friday, so it's February 6th, and we have Dr. Don Grant, who's going to be speaking about technology addiction. Very exciting. So please do call Vanessa and RSVP, and we hope to see all of you there. And Happy New Year, and I'm really excited to hear Dr. Golden today, and glad Josie's out of bed.
And I wanted to thank Benchmark. They're going to be our sponsor.
Benchmark is going to be our sponsor, and Millennium
Yeah,
for the next
Thank you,
luncheon.
Larry.
Yeah. Okay. Everybody enjoy your lunch.
Enjoy your lunch. We'll
And then
talk
we
again
have
in a little bit.
Yeah, and then we have a
Savannah. Savannah, you want Savannah? But you haven't had Savannah hasn't had the mic yet.
She loves the mic.
She loves the mic. That's why we've been holding it from her. No, I'm kidding.
Can't get her off.
Take it, girl.
I'm Savannah. I'm from Milestones Ranch. I work in admissions and some of the clinical outreach. And I am very happy to be here today. Thank you so much. And I can't wait to hear Dr. Golden speak. We absolutely love having him on the team. So thank you guys.
Okay, enjoy, guys.
So we got to work together in 2006 at the Betty Ford Center. He was come out along with addiction medicine fellowship program. And for about 10 years, the passionate man, he's a nice man. He's board certified in addiction medicine, internal medicine. He's got a degree in psychology. And he was inpatient medical director at the Betty Ford Center. Currently, right now, he's medical director for Milestones Ranch. He's also medical director for the addictions program at San Gabriel Valley Medical Center. He's a member of CSAN. He teaches the new doctors how to practice addiction medicine. He's my friend.
He's Dr. Jim Golden.
He's golden.
Testing, can you all hear me back there? Okay, yeah. Hey, can you all hear me? All right, thank you. You hear me in the back? Thank you very much, Jim. It's really a pleasure to be here. This is really wonderful. Josie and Jim, it's a great thing, and thank you for inviting me. What a great collection of professionals going around hearing who's here. Most of you are a lot smarter than I am, especially in this field. Practicing oncology some years ago, if I'd have scripted that I was going to be up here talking about the brain and addiction at this time, I wouldn't have believed it. Josie, when contacted me and said, "Would you do this?" I said, "Sure. Let's pick a topic." And then we picked this topic, and I really knew I was in for it when I got going with it, because it really put my foot to the fire, a rich topic. So I'm going to allow plenty of time for questions and input from you, because it's really important. The work that we're doing, the work that I was doing, that we were doing at Betty Ford Center, that we're doing at Milestones, is important. But what happens with when these patients leave? How do they sustain their recovery is so important. And I posed the question, you know, we get them started. Treatment works in addiction, but what happens? Why is the relapse rate so high? And why are they so compromised? We're going to look at some of that, and I'm going to try to correlate that with some of the areas of the brain. You know, our patients are out there. How many of them really get to treatment? Maybe 1 in 37 get to treatment. And the rest of them probably die from the disease of addiction, one way or the other, under the radar. So we get to help 1 in 37. And, you know, the journey of recovery, happy, joyous, and free, but they're looking at it as it's almost impossible. So I'm going to introduce you to 2 books today. And I'd like you to try to pick them up and read them. One, if you already haven't read it, is The Gift of Imperfection by Dr. Brown. How many have read it here? Yeah, isn't that great?
Oh, she's amazing.
Yeah. And so I love this quote from the book, and I wanted to start the lecture with it.
That's my favorite.
Pardon? Got it? And this is what we're going to talk about today. And we're going to talk about the brain because this is what the disease of addiction is all about. This is where it centers. And this is why people have problems when they leave treatment. I like to kind of, I was thinking about this, I like to kind of envision treatment as like getting the addicts, the willing patients, whether they come to us by intervention or whatever, into a big 747. And we get them cruising at 40,000 feet. We give them all the tools. And then we leave them. And then they have to maintain that flight. And they do okay for a while. But if they don't keep it up, if they don't go back to school, if they don't upgrade themselves, eventually they can't sustain themselves in flight. And here's a sagittal section of the brain. For those of you who are going to talk about more of these areas. Why is it that our patients come to us so compromised? Is it just dopamine? It can't be just dopamine, can it? It's got to be more than that. So here's the mesolimbic brain. Okay, this is where the dopamine is released, so you get pleasure. Here's the cortex. Why do you know this already? The nucleus accumbens, the reptilian brain, the thalamus, the locus coeruleus, the center of the noradrenaline feedback loop. So really, you know, the brain is where it all happens. Let's just talk about addiction. I know this is like remedial to many people here, but it doesn't hurt looking at it again. You know, as an oncologist, I used to put up slides about cancer and breast cancer and colon cancer, but I very rarely could use this word, preventable illness. Sometimes, yes. And now we had colonoscopy and so forth. But when I was practicing, we didn't have all those great tools early in my career. But look at that. It's the leading cause of preventable illness and death in America, addiction. Phenomenal. Right? But who takes advantage of that? Look at the cost to taxpayers. 40 million Americans diagnosed with addiction. Now, and it's a brain disease. Most people don't believe that. They'll give lip service. They'll say, oh yeah, I know. But they don't really believe it. And treatment works. The only thing is you have to sustain it with daily action. And that's the key. Because the brain will not allow you to, the brain will recapture the disease, capture the disease, and kill you. So addictive disease is a limbic brain disorder leading to excessive effects of dopamine. Remember, it's not the actual volume of dopamine, it's the effects of dopamine. Now, you know, just like all diseases have their symptoms, That comes in a minute. Manipulation, denial, comfort-seeking, dishonesty, self-centeredness are symptoms which lead to adverse consequences. These are the symptoms of addiction. Why does that happen? Why does it happen? I don't really know. Does anybody?
Low self-esteem.
Yeah, but I mean, Glenn, why does that happen? It's it.
Trauma.
Yeah, well, that's part of the answer, and we're going to look at that. Depression and anxiety, personality disorders, and then you have medical consequences like too much alcohol and peripheral neuropathy, and premature death. And then when these consequences start happening, we access our medical system, and this is what we get confronted with. Sometimes. Or this. Look, you've got to stop taking that one little pill. Look, you've got to stop thinking that one little pill is going to solve all your problems. You need to take at least 4 twice a day. Like opiates, right? Yeah. All right. Or this. And then what happens? Then patients with the disease of addiction turn away from the medical system. And let's face it, folks, physicians are not educated in addiction or how to treat addiction. It's just a sad fact. I think we're doing better, but people like you need to get out there and spread the word. Addiction is a brain disease. It's not secondary to another psychiatric illness. It's not an ethical problem, or a personality disorder, or a choice, or a demonic curse, or a transient physical dependence, or a moral turpitude. But believe me, there might even be people in this room that don't believe that. I doubt it. Now, the definition of addiction goes beyond this, and that's why our patients come to us so compromised. It's not just dopamine. We're going to answer that question. It's a disease of the brain's reward circuitry. It's in the limbic brain where excessive signal of the reward is induced by addictive substances. Now, normally, people's higher cognitive centers kick into gear. And if people are sitting in a bar who do not have the disease of addiction, and it's 2 o'clock, they would say, I better leave the bar because I think my blood alcohol level might be approaching the upper limit of normal, and it's a better idea to do that. But people with the disease of addiction, their response is, "I'll have another." And another, and another, and another. And there is no rational reason why that happens. It is probably because of some mechanism where these higher centers are hijacked in the frontal lobe, vis-a-vis the reptilian brain. For a minute, let's just look at the simple definitions. So it leads to powerlessness. It feeds on self-centeredness and sensitivity to criticism. It leads to a robbery of the self. But why doesn't the patient seek help? Why does the patient continue to deteriorate? Abstinence is necessary but not sufficient for recovery. And getting well involves a spiritual dimension that overcomes self-centeredness and dishonesty. It's not good enough to quit. Some kind of a spiritual solution, and that's even a misnomer. But in our treatment centers, folks, it's not just patients coming in wanting the substance to feel good. It's all of these patients that are fraught with complications. And so this is part of the answer. Chronic pain, trauma, and addiction. And how many of you know that, have noticed that there's a combination of all this? That there's trauma involved with addiction, there's chronic pain involved with addiction, and they occur concomitantly, frequently. And what does that do to the brain? Again, a very compromised patient. It creates disorders of thought, cognitive distortions. Disorders of motivation, attention, expectation, and value-based decisions or goal-directed actions are devoid, and instead the patients have stimulus-directed actions. Now what I mean by that is they're impulsive, hopeless, passive-dependent, and passive-aggressive. And I know that a lot of you know about frontal lobe function and frontal lobe distortions in this regard, but the reason is this. We're going to spend a few minutes on this slide. I don't know how many of you have seen this slide, but it's a really important slide. In trauma, stress, or addiction, there's frontal lobe shutdown. And if you'll notice, this part of the frontal lobe monitors reality testing. This part monitors attention and thought, and this part inappropriate actions, and this part regulates emotion. These are the emotional centers of the brain. During stress conditions or addiction or trauma or any kind of brain trauma, there's loss of prefrontal regulation. So the patient is driven by bottom-up regulation. So this is a stimulus-driven person. This would be the hypothalamus, the amygdala, which is emotional associations, and so forth. Let me give you an example. Let's suppose that somebody came to the door and opens the door and walks in. Somebody who has a shutdown, somebody who does not have a shutdown frontal lobe would look at this person and say, well, the person's well dressed, the person's not carrying any weapon, seems to be presenting himself in a non-threatening way, has a smile, everything seems to be okay. I guess everything's intact, and the person goes and sits down. Everything would be okay. A person activating off of a shutdown frontal lobe would look at this person, and maybe this person had a body habitus that reminded him or her of an abusive uncle. And up comes a remote fear from the past. And then all of this anxiety is driven. But there's nothing in the frontal lobe to regulate that, to say, we're okay for the present. And then all of a sudden this person gets up out of his or her chair and says, I have to get to a safe place. I have to leave the room. And everybody says, well, what's wrong? Well, that person just entered the room. This is a problem. And there's other physiologic things that start to happen because there's no regulation. This is very common. And this is the reason that we have compromised people coming into treatment. There's this shutdown and this collapse of cognitive processing. It's not just psychiatric disease. It's brain trauma. There's also circuitry mapped out for fear. Circuitry mapped out for many things in the brain. And I was talking to someone before the lecture here about, neurotransmitters and chemicals. And that's true, but neurotransmitters and chemicals don't work if the brain is damaged. I mean, you can pump all the dopamine you want to into a damaged brain, and it doesn't matter. You can pump all the alcohol you want to in a brain where GABA is downregulated and GABA is broken. So that's why we have patients like this coming into treatment. and that's why there's so much fear. Let me back up a little bit. You'll notice in the fear circuitry an accentuation in the locus coeruleus and the sensory cortex. This is the locus coeruleus is significantly hypertrophied in acute opiate withdrawal. I mean, prolonged opiate use, and this is where clonidine helps, as a matter of fact. A lot of fear in opiate withdrawal, fear of survival. Give me back. You can't take my computer away. You know, I need to have to have my cell phone. All of these. If you take this away, I can't survive. This is all brain injury. All frontal lobe damage and brain injury. Now I'm going to introduce something new to this group. Many of you may have heard of this, some may not, about the insular cortex. Now, insular cortex has not been talked about in the addiction literature very much, but it's starting to be. And it's imaged here, and it's a very interesting place in the brain. It seems to be a place where there's a wellspring of human emotions. It lights up with craving and empathy. It's the place where you can identify being a human being. Interesting, patients who have infarcts that involve the insular cortex, who are smokers, never have the desire to smoke again. That's been published. It reads the physiologic state of the body and then generates subjective feelings that bring about actions. It's a very interesting place. There's a concept of interoceptive awareness, where you can, if you actually pause and listen to your heartbeat and concentrate inward, it's an interoceptive awareness. Now I'm mentioning this for a reason, because we're going to segue into what to do to sustain your sobriety. And this is one mechanism of like mindfulness, which could be very important. It's also implicated with major depressive disorder, and there's some work being done in this field. So I'd like you to check out the insular cortex and some of the readings going forward, and keep a lookout for it in the literature. You're going to see more about it. It's a very important place. So if you look at profound brain dysfunction, and you look at the triad of the frontal lobe, the insula, and the hypophyseal pituitary axis, so you've got the epinephrine triad, the frontal lobe dysfunction, and the insular cortex. If you go into here, you're looking at something that's just off the charts almost. I believe we're seeing patients coming in with brain trauma from addiction. Okay? The chemicals have caused trauma, injury to these areas of the brain. Let's look at some SPECT scans. Single photon computed tomography. There, that's normal. Heroin. These are just nice pictures. Alcohol. You know they're going to be abnormal. Confirming the fact that chemicals are causing abnormal distribution of the tracer in the brain. These are functional studies. Methamphetamine is a particular bad actor, long-term psychomotor impairment. I was talking to one of the counselors at Milestones yesterday, that probably maybe when we have our interactive session, someone could help me with this. I'd like to see, in a perfect world, a methamphetamine treatment center where it's 6 months minimum, and you have to sign away your rights to leave. You have to stay. You can't leave. At least you can give your brain a chance to get better. There's so much damage, so much impairment. That is so pathetic, so horrible, so compromised, these patients. I think these are the patients that turn away so quickly. So I don't give myself any credit. Patients come in, they're pretty compromised. I think the one thing that I've learned, if I've learned anything, which is probably not very much, is time, the tincture of time. We can let the brain heal. So in polysubstance detoxification, we're using, it's a dynamic process. No one size fits all. And it's dynamic. Every patient is different. Every taper is different. I always say, what is the brain showing me? Okay, every withdrawal is different. Every GABA has been down-regulated differently. Some of you people that are doing detox now may want to also confirm this. Patients need to know that we're providing a safe environment, establishing trust. There's so much fear. I included this slide because it's just been always a question for me on alcohol delirium. I absolutely have no idea why that occurs. Why do patients suddenly, at 2.5 days, go into a florid delirium? I know it's trauma, and then they come out. Everybody panics. We have to go send the patients to the hospital, MRI scans, IVs, ICU, and they're all the same. They just go into this delirium. It's all trauma. Withdrawal, delirium. Withdrawal is traumatizing. The brain undergoes trauma during withdrawal. I put these little benzodiazepine things, fixed schedule and symptom triggered schedule, because I don't think it makes any difference. If somebody's got, it can enlighten me, I'd like to know. Maybe cost-wise it does, but I've never heard anybody say, I'm staying sober because my detox was so bad. By the way, my sobriety date is April 19, 2003, and mine was really bad. That's not the reason I'm sober today. It's only by the grace of God. And this is where, unfortunately, a lot of the patients end up, all right? Whether they have a short-term benzodiazepine taper or a protracted one. I don't want to be a therapeutic nihilist, and I don't want to be cynical. And I think treatment works. I'm an advocate of chemical dependency treatment and long chemical dependency treatment. 90 days is the gold standard. Bingo. And it works, and that's where we give these patients a chance. But what have you done for me lately? The brain wants to know. Papaver somniferum, all right? I put this slide in here to let you know that the opiate receptor is asking for donations. Okay? It wants buprenorphine or a full agonist opiate, and when it gets it, it sends messages to the brain. This is a lit up scan on opiate receptors and where they're going in the brain, where they are in the brain. And whether you put your patient on buprenorphine or methadone, it's an opiate. An opiate is an opiate is an opiate. Now, I'm not going to read this slide, but I'd like you to know that opiates poison the brain. There's a subset of patients in whom long-term buprenorphine, substitution therapy treatment is life-saving. Okay, maybe the hardcore slamming heroin drug addict veteran who's in the clinic today who will die and relapse if you don't give it to them. I agree that absolutes are ugly, but for the most part. And here's another thing here that is important, I think, to put out there, is that when patients come in the chronic pain clinic, and they say to their doctor, I have more pain, and the doctor increases the opiates, they're not, the word pain is not the operative word. What they're really saying is not pain. I have more like anxiety, discomfort, dysregulation. My brain is traumatized because that's what opiates are doing with this upregulation of NMDA or hyperalgesia or whatever. It may be perceived as pain, and that's how that ends up sometimes. Chronic stress results in frontal lobe dysfunction as well. Stress alters midbrain chemistry by resetting the pleasure set point. So if I'm looking at a beautiful flower in a treatment center and say, ooh, that's a beautiful rose, it only requires a certain level of dopamine for me to say that. If I go to 6th, 9th, and Fig and look at a beautiful rose, it requires a higher level of dopamine for me to say that. A dopamine surge. Dopamine has to be reset. Addiction is a fatal disease. We see compromised patients, probably because of brain trauma. They're coming in because the substance has caused brain trauma. We know what addiction is. We know how it operates. We know where the lesion is. Probably it affects 8 to 15% of the general population. Treatment works. It gets them started. They're cruising at 39,000 feet in a big old luxurious 747. Now what? Let's look at practical solutions. What needs to be done? Well, that's Guadalupe Island, right off the Mexican coast. Nothing but flowers and fresh water and utopia, right? Not too practical. But the brain will certainly get better there. And if there's no controlled substances, it's possibly an answer, but not too practical. There's FDA-approved agents. These are short-term solutions for a long-term problem. I'm just going to say that about them. I'm not going to dismiss them. I happen to think that most of them don't work, but I'm not going to say don't use them. I think they have their place, but not forever. You're not going to find very many people with 10 to 15 years of sobriety still using them. You can just say no. But I'm not sure. That's going to work.
I need a picture of that. Wait, don't do it again.
Now maybe we're getting somewhere.
I'm just kidding.
Okay? Would you all agree with this?
Yes.
All right. Can the brain get better? Yes.
Yes.
Neuroplasticity, the ability of the nervous system to modify and so forth. In response to experience. So here, let's look at components that work in treatment and extrapolate those out to what we can do going forward. Group process, mindfulness, movement, acupuncture, external qigong, trauma work. Most of these we can carry forward in some way or another. What gets better after chemical dependency treatment? All these. Everything gets better. Look at them when they come out of treatment. They're not catastrophizing. They're spiritually based. They're centered. They're goal directed. They're not stimulus directed. They don't have a bias towards bad feeling. All these are better. Why can't they sustain it? It's the daily work that they need to do. Sleep is better. Prolonged stress response. You know, the patients at Milestones are so much better, and they get better on a weekly basis. I see them like once a week, and every week it's leaps and bounds progress. And these are really compromised patients when they come in. All right, 12 step. That's one thing you could do, but look, there's no facilitator, no therapeutic approach. Group attendance varies, no attendance required, no participation, no drug testing, and a desire to stop drinking is the only, but it works. Why does it work? Why does it work? Which step says don't drink? None of them. It's all action-based. It's all getting out there. It's all doing stuff. It's making direct amends. It's grounded in action. I was reading the other day in the reflections. You know, you can engage in prayer and meditation all day, and it doesn't do any good unless you take action.
Sorry, I didn't get that.
I accidentally pushed it, I'm sorry. I'm Siri's recording you.
I get the message. Thank you.
Siri did that.
Neurocognitive enhancement. This is what helps make the brain better. Stimulate the frontal cortex. Develop an inquisitive mind. Become a student. Attenuate the stress response. Presence. Mindfulness consciousness. Change the focus of attention. All this is on the prior slides. Movement, Tai Chi, yoga, Kung Fu, Qigong, and breathing. Now I talked about the insular cortex. This is interoceptive awareness. It seems that many people who have stayed sober for a long time believe that connecting with their condition daily is important. And this is a key, whether that be vis-a-vis meditation, vis-a-vis whatever it is, pausing, reading the reflections, understanding that they're grateful for their life today. It can be very simple, folks. Understanding that they need to stay sober somehow, whether it's calling a sponsor, whatever it is, it can be very simple, but it has to be something. And somebody has to motivate sometimes a person to do that. So interoceptive awareness, I would ask you to look into this. This is a really powerful tool that can be utilized for some of your clients. Usually it's associated with monitoring heartbeat and connecting with your heartbeat. Some of you may have some experience with this. We may have time for you to share about this. This helps with emotional dysregulation, with distorted cognition. All the distorted cognitions when patients come in, and then how it improves. That's all the brain getting better. Change the environment. Ask your clients. Change cognitions and emotions by setting up the environment for sober success. Set up cues as a reminder to take action. Meetings, meditation, interoceptive awareness, therapy session, visual aids, auditory aids. Have tools in the environment to support sobriety. Relocation if necessary. This is a list of practical tools which you can actually correlate with brain areas. Employment. Now, you know, that sounds like an arduous task, but it's really important. Accountability, tasking, showing up, tasking, frontal lobe, unexpected gratitude. Huge. Employment's huge. It can be the simplest thing. It can be part-time. It could be volunteer. Well, but it's better if it's some type of employment where you're held to task. Physical exercise, endorphins. This also goes along with movement. as part of the brain getting better. Daily introspection in the form of meditation or interoceptive awareness, connecting with the condition of the alcoholic addict. Connecting. I know I'm an addict and I'm grateful for my life today. In a real sense, in a genuine, authentic sense. Engage in some kind of group encounter. Now notice I don't have AA up here, but AA would be a good group encounter. It can be anything but a group, because in a group you get feedback, and people do and get into a group where they don't co-sign your BS. See, because that's how those layers of denial get peeled off. And believe me, I'm still peeling those layers of denial off after these years. And probably will continue to. Be of service, huge. Service, so important, getting out. If I start isolating, my brain takes over and I'm doomed. That's it. It's going to tell me I don't need to do anything. The hardest thing to do is to ask for help. That's the hardest thing to do, is to pick up the phone, to get out of my self-centered self and ask for help. Psychodynamic psychotherapy. Oh, did I leave out have a mentor? Have several mentors. I started writing. I actually do some stage writing. I have a writing coach. I have a therapist is one of my mentors. I have mentors. I have all the mentors I can possibly have. Jim's one of my mentors, believe it or not. Mentors. The more mentors, the better. Psychodynamic psychotherapy, huge. Develop as long as you can. A primary care physician who understands addiction, and back to school or develop a hobby. Now, I'm not perfect, but if somebody can do some of these things and engage their brain to be reminded to take action to keep recovery going, there's a chance that they can stay sober. Because this disease of addiction is so overpowering. And the brain wants to go back.
If we leave our clients sitting in a halfway house after they complete treatment for 21 hours a day, they don't get to do those things, they're not going to make it. If they sit around and play video games all afternoon, and they play video games until 2 o'clock in the morning, okay, change. They have to. They need that stuff.
But just one more thing, and we're almost done. And we'll get some feedback.
I just couldn't.
All right.
He couldn't stop himself.
This is for you. This is for you. Sorry, Jim. This is for you. This is a little exercise. I like to present this. You're all healers, and so I like to do a little self thing. You can take your own inventory here.
Okay.
Am I a victim healer or an empowered healer? Do I operate from the past, or do I operate from the present or the future? Do I react or do I respond when I'm dealing with my clients? Are circumstances bigger than me, or am I bigger than my circumstances when I show up for work? Is there not enough, or is there enough? Do I operate from a position of guilt, blame, or resentment, or acceptance, forgiveness, and compassion? Is it up to someone else, or if it is to be me, it's up to me? Do I operate from wish, hope, or want, or I make it happen? Duty, burden, obligation, or opportunity, possibility? Fear versus love and courage? Resignation, or my vote counts? Or my past beliefs, or I create myself in the now? Now, The last is a book I'm going to refer you to. He is one of my heroes and mentors, Sean Newland, N-U-L-A-N-D, and he's one of the greatest physician writers, I think, of the last century. He wrote the book How We Die, and he just actually died about 2 months ago. And it's a wonderful book. It was actually included in the Classics of the Medical Library. It was written in 1993. The last stanza of the book, basically, I'm going to show you in the last slide. I'll leave it up during the discussions. Is basically, I'll just leave it up and you can see for yourself. Let's have a little discussion about what you think some of the practical remedies could be to staying sober. And any comments about brain trauma or what you think you'd like to add?
I'd like to hear a little bit more about, for example, EFT, which decreases the size of the amygdala when you're working on it. And I love your mention of mindfulness meditation because that actually makes the frontal lobes larger, increases the gray matter, and allows us to affect the limbic system more.
Well, you know, I'm not, the information, I'll tell you, the information I'm aware of, I'm not aware of any data that support any useful clinical transition on that. If you are, I'd like to hear about it. Go ahead.
Well, I mean, I just have a lot of data that I can try to do a lot of studies.
Okay.
When I look at them, also same thing with EMDR and
Yeah. What the thing is that I didn't include some very interesting information about cannabis and the decrease in volume in some of the motivational areas of the brain. I probably should have done that, which I think is relevant and pertinent. But I'm not sure how practical that is. I mean, it might be, but and that's a good point. Yes.
Yeah. Any reason why you just Suboxone wasn't on the list of those other?
Suboxone for what?
You had the list of medications that...
No, not really. I tried to include it in the opiate version with buprenorphine. But, you know, I mentioned it as opiate, but not as a long-term solution. Do you have any suggestions about long-term Suboxone?
No, I was just wondering if it was excluded from the list because you thought it was different.
No.
Okay.
No, I had it up there with buprenorphine in that one slide, but I think I mentioned opiate substitution therapy as along with methadone.
Okay, thank you.
Yes. Sure.
I really like the way that you kept saying that is there a cure or not cure? Can there be change? Yes, there can. Can there be improvement? Especially with what we know now about the brain and neuroplasticity, so much improvement can happen within the brain and the brain trauma that you mentioned.
Right.
So much of that can be reversed and we can build new positive neuronal pathways and eliminate the bad ones.
Right.
By no longer using them.
Right. Well, yeah. To be honest, I'm not a neurologist, and I think that some of the work being done now in the neurology sector in the specialty areas is really exciting. I'm not sure if this is going to be widespread within the whole, available to everybody who suffers from the disease of addiction. See what I'm saying? So when you get somebody who goes to a treatment center, who comes out, I mean, they're given the test of time. If they practice some of these tools, I mean, they will get better. The brain will get better. I think the areas of the brain that are vulnerable and that are affected, I think it's pretty clear we've mapped those out to the best of our ability. That's my understanding. Now, I didn't go into some of the psychiatric comorbid states, which are important. And there is, treatment. There's psychotropic drugs, which need to be treated. I mean, there's bipolar disorder that needs to be contained. These are other considerations that have to be addressed, obviously. So it's not all just addiction. I mean, there's a certain segment of the population that suffer from psychiatric disorders that have to be medicated. So, yeah, but I'm not, I guess, so anyway, that's...
With a developing brain, the brain doesn't develop until like 25, right? It doesn't grow into its space. Has anybody done a study on the damage we do to a 24-year-old, to a 30-year-old brain after putting it on Suboxone for, for 6 years while it's still forming? Has anybody done any looked at that?
Yes, there's some studies out there.
Do they bounce back, or do we alter them?
Keep it trying to answer, but it is
I haven't seen anything. Go ahead.
The studies that I've seen show that there's all sorts of things, like 5 years of consistent chronic marijuana use, chronic being 1 time a day, and we know marijuana smokers obviously, after 5 years, they lose 1/3 of the IQ, and it's not regained. So, that, I can forward you those studies that I have, Jim. They were given to me by the doctor at Lucinda Treatment Center in Florida, because I was working with teenagers and sharing with that. And then they were showing the long-term, especially with the level of THC now in the altered marijuana, that the studies, it was a study against methamphetamine, where we were talking about how long it takes to recover from methamphetamine to the brain to recover. So they were showing that a year post-chronic marijuana use, again, chronic being 5 years, 1 time a day, a year later they weren't seeing the recovery in the brain that they were seeing in methamphetamine.
Wow.
So I think we're going to start seeing a lot of changes, with all of the legalized marijuana. But so there's a couple of studies that are out there. There's also contradictory studies because there's a lot of proponents for marijuana that are also doing studies. So, I think we're going to see a lot of back and forth fighting in these studies, but those are the studies that I've seen out there right now.
I just want to add to that. It's a lot of additives that are in marijuana that wasn't in when I was younger. They're spraying the plants now that's making the children or adolescents or adults, hallucinate. So there's the studies. Yeah, absolutely. And also the levels of THC, now with the dabs and the wax and all of these things that are such increased levels, sort of the injury to the brain, like Dr. Golden said, it's all about brain trauma and brain injury from the chemical.
Well, I didn't mention that some of these studies because, to be honest, there is a lot of studies out there trying to correlate brain areas and decreased volume and function. And I'm just not sure. They're small studies, some of them. They're trying to correlate this. And to be honest, it's pretty confusing. There's not a lot of follow-up, not a lot of validity sometimes. I think it's fair to say, though, that where there's smoke, there's fire, obviously. You've got marijuana or THC. I think, like you say, there's other compounds in the THC. There's how pure is it, what percentage. Frankly, I take 3 of these journals, and every time there's 2 or 3 articles along that line. If I were to look at all the studies and compile them together, I think it would just be, yes.
I missed the name of the book, so I'd like that name of the book.
This one?
You said you had a favorite book.
How We Die by Sherwin Nuland, L-U-L-A-N-D.
I didn't see
on my presentation, first of all. And I didn't see anything, and I'd love to get your thoughts on diets in regards to the brain, and also like amino supplements or things like
Well,
that. that help the
yeah,
brain.
I haven't seen anything in the addiction literature that dogmatically supports a specific diet as a remedy or a boost to accelerate either the cure or the rapid, resolution of an addiction problem. Now, I haven't seen it. If somebody here has information, I would really like to hear it.
I've got information from the latest research that was presented at the American Academy of Anti-Aging Medicine. As you're most definitely aware, inflammation is the root problem from trauma or from drugs or alcohol or whatever, concussion, brain damage. It brings on inflammation. So anything that can ameliorate the inflammation is a reduction factor in disease, I would say, in my opinion. The studies or the data that you want to find that would be in the information in medical literature. But as you know, there's not very much research or statistics built on this yet. It's a burgeoning science.
Yeah.
So there's repressed therapies that reduce inflammation. So, but anything you can do to reduce inflammation is very important factor. One question I had, or actually I had a comment on your delirium. Michelle brought up diet, which would indicate detoxing pathways and other pathways. I would think that the delirium is caused, it just struck me that it's just toxins coming out of the center of the brain. And as those toxins are moving, you're experiencing a space that you were in when you were under the influence, or something to that effect. If that resonates, I would put that out on the table. That's a big possibility. It seems to me also I've come across the information related to a doctor recently that said that anytime your brain is hit or traumatized, it goes in overdrive and it never quits. So once you traumatize your brain, you're in overdrive. It's going to be constantly doing that thinking processes to the extreme once you set that stage. And I don't know if there's a reversal for that. And then I had a curiosity as to why you focused on dopamine rather than or not bring up acetylcholine or norepinephrine or the adrenal hormones or I don't know why serotonin isn't a factor as well. Why is dopamine the key neurohormone that you focused on when you're talking about the addiction?
Well, I'm not sure that any of the hormones per se work at the end organ in a traumatized brain. Period.
Okay.
See,
so it's a matter of physicality of the synapses.
When you get to the level of a severely compromised patient, I mean, a lot of this is conjecture. The brain. I just think it's all conjecture when you do that. We have end organ. It's sort of like what does a free thyroxine index mean? I mean, what does a T4 of 4 mean if somebody's euthyroid? See, it depends on what the response is to the end organ. We can talk about hormones all we want to in the brain, but if the brain is traumatized, it doesn't matter. It's not going to.
It also has to do with the methylation pathways that are perhaps screwed up from birth.
Or at least before it was traumatized.
So do you think that might be a focus of treatment is to look at re-regulating the dysregulated methylation?
No.
No. You think it's an organic structure in the brain?
You mean addiction per se? No, I think it's genetic vulnerability
trauma and something in the environment.
Enjoyed everything you had to say about the research. I was working with Dan Siegel, and a lot of his research around mindfulness is really interesting. However, I like that you had a list of practical interventions that involve action for the addicted person who's been through treatment and needs every day to do something. Meditation is one of them. Tai Chi, calling a sponsor, calling a sober friend. Every day that person must have an application to be sober.
Thank you. Thank you very much.
I want to thank Jim for speaking. I want to thank our sponsors for supporting this event. It's 2:30 on a Friday. You guys are getting a little busy. We just gave you sugar. You can all go now.
No.
Oh,
we gotta get the raffle.
Okay.
We have 2 raffle gifts, ATS and Sovereign Health.
Okay, you have to be present to win, so don't go.
You can't go, sorry.
Right, that's Josie's rule. Okay, so we've got a $25 Starbucks card.
That's from
Thank you. Thank you very much.
From Sovereign Health. And the lucky winner is Darlene David. Darlene David!
Tipping for you.
Hey, good job.
And the other one is?
Yeah. Awesome.
Okay.